So today we are going to start a new chapter, that is the pelvic organ prolapse. So pelvic organ prolapse is the herniation of pelvic organs to and beyond the vaginal wall from their normal anatomical position. And the pelvic organ prolapse is caused by failure of interaction between the levator and eye muscles and the ligaments and fascia that support the pelvic organ. So the pelvic support is provided by the muscles, ligaments and the fascia. And the levator and eye muscle include iliococcygeus, pubococcygeus, and the puborectalis muscle. Next one is the level of pelvic support. The first one is level 1 support. Level 1 support is provided by the ligaments, that is uterosacral ligament, and this ligament attaches the uterus or the cervix to the sacrum, and its deficiency result in the vaginal wall prolapse. Level 2 support is provided by fascia. Anteriorly there is pubocervical fascia, which is present in between the bladder and the vagina, and its deficiency anteriorly result in anterior vaginal wall prolapse. Posteriorly, the support is provided by the rectovaginal fascia, which is present between the rectum and vagina, and its deficiency posteriorly result in posterior vaginal wall prolapse. Level 3 support is also provided by the fascia, but it is present between the distal posterior vagina and the perineal body, and its deficiency result in the lower posterior vaginal wall prolapse. Now let's talk about the anterior compartment prolapse. So anterior compartment prolapse include the herniation of anterior vaginal wall, which can be cystocele, urethrocoele, and the cystourethrocoele. Cystocele involve the prolapse of the bladder. Urethrocoele involve the prolapse of the urethral descent. In the cystourethrocoele involve the prolapse of both the bladder and the urethra. Next is the posterior compartment prolapse. So posterior compartment prolapse is defined as herniation of the posterior vaginal wall, which can be enterocele or the rectocele. So enterocele involve the small bowel descent with the upper one third of posterior vaginal wall, and rectocele is the rectal descent with the lower two third of the posterior vaginal wall. Next is the apical compartment prolapse. So the apical compartment prolapse include the uterus and the cervix. So there may be a prolapse of the uterus with inversion of vaginal apex occur, or there may be prolapse of the cervix with inversion of the vagina occur. Next is the vaginal apex prolapse, that involve prolapse of the upper vagina to the vagina, and the last one is vaginal wall prolapse, which occur after the hysterectomy. So the apical compartment prolapse include prolapse of the uterus, prolapse of the cervix, prolapse of the vaginal apex, and the vaginal vault. Now let's talk about the etiology of the pelvic organ prolapse. So the first one is the multiple vaginal delivery. So the multiple vaginal delivery, they increases the risk of the pelvic organ prolapse. Second one is menopause. So after menopause, the risk of the pelvic organ prolapse increases. It occurs because of the deficiency of the estrogen, which causes the loosening of the connective tissue, and hence increases the chances of pelvic organ prolapse. Next one is the iatrogenic causes. So the pelvic organ prolapse may occur because of certain iatrogenic causes of the pelvic surgeries that include the vaginal hysterectomy or birth suspension. Certain other chronic factors that contribute to the pelvic organ prolapse also include coughing, constipation, heavy weight lifting, any pelvic mass or tumor, or there's excessive straining. All these factors, they increases the intra-abdominal pressure, and hence they lead to the pelvic organ prolapse. The other causes that lead to a pelvic organ prolapse include the prolonged labor, there is injury to the pelvic diaphragm, there may be injury to the pudendal nerve that supply the pelvic diaphragm, or there may be certain connective tissue disorder that include Marfan syndrome, Ehlers-Danlos syndrome, which also lead to the pelvic organ prolapse. And there is another factor, which is birth trauma, which may be a cause of the pelvic organ prolapse. Next one is the grading of the pelvic organ prolapse. The first is grade 0. In grade 0, there is only displaced uterus, but in grade 1, the prolapse does not reaches the hymen. In grade 2, the prolapse reaches the hymen. In grade 3, the prolapse is outside the hymen. In grade 4, there is complete progedentia. Next is the sign and symptoms of the pelvic organ polyps. First one is the general symptoms. So the most common sign is something coming out of a vagina or peeling up a lump coming down. The other symptoms include dragging sensation or discomfort within the pelvis, dyspareunia, which means painful intercourse. Idea is back pain occur or difficulty in inserting the tampons. If there is a cystourethrosis, there will be urinary symptoms like urinary frequency occur, urgency occur, there is incomplete emptying of the bladder occur, there may be urinary retention occur, and there are recurrent UTIs occur, and there may be stress incontinence occur. And if there is rectocele, there may be constipation occur, incomplete bowel emptying occur, there may be digitation or splanting occur. Let's talk about the support of the pelvic organ. So, first one is the muscle support of the uterus and vagina. So, the muscles that support the uterus and vagina include bulbous spongiosum, levator, ani muscle, external anal and urethral sphincter, superior transverse perineum, and the deep transverse perineum. Next one is the mechanical support. So, mechanical support to the uterus is provided by angle of anteversion, angle of anteflexion, and the round ligament, which keep the uterus and the inverted position. And the last one is the ligamental support. So the ligament that provides support to the uterus and vagina and the cervix are pubocervical ligament, transverse cervical ligament, and the uterosacral ligament. Let's suppose this is the pubis and this one is the cervix and vagina, and posteriorly we have the rectum, and this one is the sacrum. So the ligaments include transverse cervical ligament, and the ligament between the pubis and the vagina cervix is the pubocervical ligament, and the ligaments between the sacrum and the vagina cervix are the uterosacral ligaments. So these ligaments include transverse cervical ligament, pubocervical ligament, and the uterosacral ligaments. Now let's talk about the investigation done for the pelvic organ prolapse. So the diagnosis of the pelvic organ prolapse is mainly clinical, but we can do certain investigations. The baselines include CBC, urine, RE, and the X-ray chest, which is done in case of the chronic cupping. Similarly, we can also do abdominal examination and the pelvic examination to exclude any pelvic mass. And a rectal and vaginal examination help in aiding to differentiate the rectocele from the enterocele. Similarly, we also do the ultrasound abdomen to exclude any abdominal mass or the pelvic mass. For urinary continence symptoms, we do the urodynamic study, and if there are rectal symptoms, we do endoanal ultrasound to assess the anal sphincter. Similarly, we also do the rectal manometry. We can also do the flexible sigmoidoscopy or defecating proctogram. Let's talk about the management of the pelvic organ prolapse. First one is the conservative treatment. And conservative treatment, we have preventive measures, so which decreases the risk of the pelvic organ prolapse. The first one is weight reduction, avoidance of the excessive straining, and also avoidance of the heavy weight lifting. Similarly, also avoid the traumatic instrumental deliveries, which also reduces the chances of the pelvic organ prolapse. Similarly, also encourage the patient to do the postnatal pelvic floor exercises, and these pelvic floor exercises are known as the Kegel exercises, and these exercises they strengthen the pelvic floor muscle and reduces the risk of prolapse. Similarly, if the patient has a chronic cough or constipation, treat it. Next one is the pessaries. So pessaries are the intravaginal devices which are inserted inside the vagina to support the pelvic organ, and pessaries are of the following types. The first one is ring pessaries, shell pessaries, Hodge pessaries, and Dutch nut pessaries. And the side effects of the pessaries include fistulas formation and increasing risk of the infection. And these pessaries should be changed after every 3 months. And pessaries are indicated in the following condition. They are inserted on the basis of patient wish, if the mother has not completed the childbearing, if the patient is medically unfit, during and after the pregnancy, the pessaries may be inserted, or if the patient is waiting for the surgery. Now let's talk about the surgical management. So surgery is the mainstay of treatment for the pelvic organ prolapse, and we have different surgical options depending upon the type of the pelvic organ prolapse. The first one is the anterior colporrhaphy. So anterior colporrhaphy is the repair of the interior vaginal wall, and it is done by the anterior compartment of the prolapse. And the anterior colporrhaphy involves the application of sutures to reinforce the fascia between the vagina and the bladder, and the complication of this surgery involve bladder injury, and there is also high rate of the recurrence. Next one is the posterior colporrhaphy. So posterior colporrhaphy is the repair of the posterior vaginal wall, and it is done by the posterior compartment prolapse. And the posterior colporrhaphy involve the application of suture to reinforce the fascia between the vagina and the rectum, and the complication of this surgery involve injury to the rectum and dyspnea, which is the painful intercourse. And next one is the uterovaginal prolapse. So for uterovaginal prolapse, we have different surgical option. First one is the hysterectomy. So hysterectomy is done in old age when the woman has completed her family and she does not want to conserve her uterus. In hysterectomy, it is important to reattach the uterosacral ligament to the vaginal wall to maintain the level 1 support and prevent the vault prolapse. So hysterectomy is done in older age when the family is complete and the female does not want to conserve her uterus. Next one is the Manchester repair. So Manchester repair is also known as the Gill repair, and it is suitable when the woman wishes to conserve her uterus and she has not completed her family. In Manchester repair, we do the partial amputation of the cervix and the approximation of the cardinal ligaments to the cervical stump. And Manchester repair may be combined either with the anterior colporrhaphy or the posterior colporrhaphy, depending upon the type of the prolapse. And the complication of Manchester repair involve cervical incompetency or the cervical scarring. Next one is the sacrohysteropexy. So sacrohysteropexy is a new procedure that is performed, and it is suitable when the woman wishes to conserve her uterus. And sacrohysteropexy involves the attachment of the uterocervical junction to the sacrum using a mesh and the closure of the pouch of Douglas. So in sacrohysteropexy, we attach the uterocervical junction to the sacrum with the help of a mesh. Now the last one is the vault prolapse. So for the vault prolapse, we do two procedure. One is sacrocolpopexy and the last one is sacrospinous ligament fixation. So the sacrocolpopexy involve the attachment of the inverted vaginal wall to the sacrum using a mesh and closure of the pouch of Douglas. And the sacrospinous ligament fixation, it is a vaginal procedure and it has a low recurrence rate, and it involves the application of suture to the vaginal vault and the sacrospinous ligament. So it was all about the pelvic organ prolapse and their management.